So that's nothing new. We will do the obliques. Which we did obliques with the upper GI and the esophagus. But now, when we do the obliques, we're just centering different because we want to get the entire abdomen region to get that large bowel on the film. So we'll do the entire abdomen on the obliques. So first thing first, I'm going to line up X-ray tube.
Okay.
And depending on your machine, you should have to have a receptor, but some of these machines, they may just send everything digitally, or sometimes they may do the overheads under fluoro, so they don't actually use the receptor, so it just kind of varies. The only thing with doing on fluoro is you kind of lose your field of size, or your size field, because it's usually kind of cones into a circular shape. I'm not sure if you guys noticed that in the PowerPoint and in the textbook. The question that I had about the positioning of the contrast and air in the stomach on the test, I don't know if you noticed that was like kind of circular and it wasn't like a rectangular border. That's how the fluoro films usually appear. Miss Wallace, scoot a little bit towards me. Thank you. All right, so you want to make sure your patient is nice and centered on the table. And another thing with these tables, I don't know if you noticed, but our table, and I haven't really been out in the sites recently, so I don't know if some of the newer equipment is different, but the tables typically aren't this wide. They're a bit narrower. So you want to be mindful of that with your patient size too, and just making sure that they're on the center, but also that they're not too close to the edge. All right, so AP. So for the BE, one of your overhead films is just going to be a regular KUB. So again, you're going to center at the iliac crest. Let me dim the lights a little bit so you guys can see the collimation here. So we're centering at the iliac crest, and then you want to open up your collimation field to the size of the abdomen, okay? So remember the abdomen, you want to go all the way up to the diaphragm, and you want to go down to the pubic symphysis, because we want to get that transverse colon, the ascending, descending, all of that good stuff in there. So for all of these, you're going to leave your collimation open, with the exception of the sigmoid and the lateral rectum. So this is your AP. Sometimes they may ask you to do a PA, which you will still center at the same iliac crest, but the patient's going to be laying on their stomach. Also, you need to do your obliques, because remember we talked about the different obliques opening up those flexures. So you have to do both obliques, because we need to see both of those flexures open. And that was a test question. All right, so I'm looking for the sponge. Can you just pass me, 2 of those? That'll work. All right, so if I'm going to do my LPO, which way am I going to have Miss Wallace turn?
To the left.
Mm-hmm. All right, so turn away from me a little bit, and I'm going to put a sponge behind you. Okay, and you can relax against that sponge. So this is going to be your LPO, all right? But you do need to check your light field, because when you oblique the patient, although you should still be at the level of the iliac crest, you may need to come over some, all right? I had talked about, Miss Wallace, turn your head and look towards the left. I had talked about using the ear as a reference for the centering in lecture. This is like maybe 2 lectures ago, but I never showed you guys. So this is where it will become helpful. So you see Miss Wallace ear? If you put the center of the X-ray beam, the X-ray crosshairs in alignment with her ear, you're going to be in the center of the body. So do you see how I'm off a little bit? So what direction should I move Miss Wallace? Nope.
Oh, Miss Wallace. Yeah.
Mhm.
To the right.
Yep, because remember, you don't want to move this because we're already synced in. So I'm going to move her a little bit over, and now I'm in alignment with the ear. Do you guys see that?
Mm-hmm.
I could probably even come over a little bit more. You all see it?
Mm-hmm.
All right, so I'm in alignment with her ear, and I'm just going to close in my collimation a little bit because I got a little extra over there. and I'm good. So by using the ear position, and it'll only work if you have the patient look towards that side. If they're looking up, you can't see where their ear is. But the ear will basically be in alignment with the spine, which is the center of your abdomen region. We're also gonna come back to use that little trick when we get into spine, because we gotta do obliques of all, well, not the thoracic, but of the cervical and lumbar. So this is my LPO oblique. So I would do this as an overhead, and then I'm gonna do my right overhead oblique.
Mm-hmm.
Instead of moving Miss Wallace, I'm just gonna do the left lateral instead of having her turn back and forth. So I'll do the left lateral and then come back to the RPO. So left lateral, ask my patient, can you turn all the way on the side for me? Okay. So Miss Wallace did it for me, but sometimes when your patient turns on their side, they're not in the center of the table, but she positioned herself back. But just be aware of that. Like when they turn onto the lateral, they may be more towards the left side. So you may have to kind of bring them back a little bit. If they can't really move that well, sometimes it might just be easier to bring the pull on the sheet. Do all of your x-ray tables have pads on them?
Ours does.
Mine does.
Okay. Do you guys, have you noticed that they put a sheet under the pad? So that's just to kind of help if they need to move the pad or move the patient. It's just a lot easier if they have a sheet underneath it for moving. Alright, so lateral rectum, so we're gonna we could use the curve of the iliac crest as a position. And if you make a C with your hand, you can kind of come in the center of that C as a reference point, okay? So I'm gonna come down, and then I'm gonna go back. I think the actual angel, since you have the book, what is the actual central ray? I think it's like 2 inches posterior toward, to the ASIS, but let me know what it says for the lateral rectum.
Says, yeah. Center at the level of the ASIS, center to mid-coronal plane.
Okay,
So
So-
between the ASIS and posterior sacrum.
okay. So our posterior sacrum is gonna be here. Your ASIS is gonna be anterior. Remember, that's that hard landmark that we could feel anterior. It's below the iliac crest. So you shouldn't be up at the iliac crest. You wanna be below that. And then you could hone in your collimation, because we're just doing the rectum. And I'm gonna go back just a little bit. So that will be your lateral rectum. When you're doing all of these overheads, you always wanna make sure that you tell the patient to hold the breath before you make the exposure, because you don't wanna have motion on there. And also, you're gonna have them hold the breath when you're doing like your APs and PAs and obliques on suspended expiration, because what does that do to the diaphragm?
Just moves it out of the way.
It brings it up higher, superior in the abdomen, so it's out of the way. Our central ray for the lateral rectum is perpendicular, so for all of them have been perpendicular. The only time you're gonna use the angle on your central ray is when we get to the sigmoid, all right? And that was a test question too. So we're gonna angle about 30 degrees AP, when you're doing an AP cephalic towards the head for the sigmoid. All right, so now let's do the RPO. So Ms. Wallace, can you lay on your back and then turn towards me? And if you have an older patient, you always want to be on the side that they're turning to, because older patients are they get scared easily. You can roll back onto your this way. Older patients get scared easily, and they always think they're gonna fall, because a lot of them have fallen before. So you always want to give them that extra comfort and have them, make sure you're there when they're moving or you're assisting them to move. All right? So how do you guys think Miss Wallace's position is?
Too lateral. Yeah.
Yep, I agree. I think she's too loud. Miss Wallace, I think your zipper's down. Your zipper.
Thank you.
Mm-hmm. All right, so I'm gonna have her relax a little bit. So what do you guys think about that now?
Mm-hmm.
Okay. And I'm just gonna scoot her a little bit towards me, so I'm gonna pull my sheet, cause I want her a little bit more in the center. And now I'm gonna go back up towards my iliac crest. So I'm centering at my iliac crest, gotta go up a little higher. I could still use the ear as a reference for my centering to make sure I'm in that mid-sagittal plane. And that will be my, which oblique is this?
Right.
So,
RPO.
right, RPO or right posterior. So you don't wanna just say right, cause you can have a right anterior. So it's my RPO. Because remember, we're gonna always do both obliques to get those flexures open. You're gonna see in your textbook, and I talked about this in the PowerPoint, you can also do anterior obliques, but typically we don't do that because normally the patient's always in a supine position. So we just do posterior obliques instead of having them lay on their stomach and then doing the anterior obliques. But you could technically do anterior obliques, but you wouldn't do both. You would either do an LAO and RAO or RPO and LPO. They basically are opposite of each other. So in this position, which is what position?
RPO.
RPO, it'll be the same thing as if you were doing a LAO. And vice versa. If you did a LPO, it would be the same thing as doing an RAO. So that's why we don't do all four, we just do two. So questions so far? All right. So the other, the last thing I'm gonna show you is the AP axial. The decubitus, I'm not gonna show you because we've already gone over that when we were doing the abdomen. But the decubitus, when you do that, you do have to do both decubitus. You're gonna do a left lateral decubitus and a right lateral decubitus. You guys saw why. That was 2 questions on the test because it shows different parts of the ascending and descending large colon. So that's why you have to do both. And you can do that in a variety of ways depending on your room and your equipment that you have. Some x-ray techs will leave the patient on the fluoro table and they will bring the x-ray tube out and then do the cross table that way. I'll show you guys that in a second. Or some of them, the x-ray tube is kind of locked into the table so you can't really do that. So they will put them up against the wall bucky, like I showed you in class when we were doing the abdomen, and do the decubitus there. Or some fluoro rooms, most fluoro rooms will have a second x-ray tube. So they'll have the one connected to the table, and then they'll have another one that kind of just floats on the ceiling, and they may bring that one over to do the decubitus on. But you want to make sure that you do both of them, and you want to make sure that you have your receptors ready so you can go quickly. When you're doing these overheads, you're not going to go as slow as I'm going right now showing you. You're going to be fast because the patient's going to be complaining. They're going to say they have to go to the bathroom. They may start going to the bathroom. So you want to start doing this as quick as you can to get the overhead images. So I'm going to take these sponges from behind Miss Wallace and have her lay on her back, facing up. So what's my angle for the sigmoid?
30 degrees.
And what direction am I going?
Cephalic.
Yep, I'm gonna go cephalic because Miss Wallace is AP, right?
Mm-hmm. In AP position.
So remember, since I put my ankle on there, I gotta come back and make sure I align here, all right?
Mhm.
Don't forget that because you'll end up not having nothing on your image. Alright, so I'm lying back up here. Now, what does it say for my centering point?
The sigmoid.
Inferior to ASIS.
What'd it say?
2 inches inferior to ASIS.
Alright, so Miss Wallace, point to your ASIS. So you wanna go 2 inches below that, okay? And then of course you wanna be midline. You can close in the collimation, you see how small my collimation is? Because you're only looking at the sigmoid region, we're not getting all of the large vowel, it's only for the sigmoid. You can in actuality, do this image on a smaller receptor if you wanted to, a 10 by 12 as opposed to the 14 by 17. And the same thing with the lateral rectum. You can do that on a 10 by 12 too. So again, the last films that you would do is the decubitus and the post-evac. Who can tell me about the post-evac?
That's after you urinate. Get
Well, not
the-
urinate.
You know,
That they go to the bathroom, so they
Mhm.
defecate. So you're gonna have the patient, once you have all your films, including the decubitus, you wanna check with the radiologist first. Make sure you send the radiologist or send to PACS all of the images of the overheads you've done that far. Check in with the radiologist. Did you get my overheads on patient Wallace? Is it okay for her to go to the bathroom and for me to take the post-evac? Because the radiologist may say, oh, I wanna see the sigmoid region fill a little bit more. Put her prone and take another KUB in 5 minutes or something. So always check with the radiologist first, because once the contrast comes out, it's out. So check with the radiologist. Once he gives you the all clear, then you're gonna have the patient go to the bathroom. So if you have a walkie-talkie patient, you can just have them physically get up and go to the bathroom. But what do you have to do first?
check with the radiologist.
And that, well, we've already done that.
Talking about what we do first when.
Before, like, once we check with the radiologist and he or she says that we can have the post-evac done, before, if you have a walkie-talkie patient, before you actually have them get up and go to the bathroom, what needs to happen? Because remember, they still have contrast in them, right?
Mm.
So how is that contrast staying in them?
With the catheter?
Mm-hmm. So with the rectal tip. Remember, they're still gonna have the rectal tip inserted in their rectum. That balloon is still gonna be inflated,
You
and
got
they're
to
still
deflate.
connected to that, barium bag.
Deflate, and then don't let some of the barium drains back into the bag,
Mm-hmm,
and then remove the rectal tip,
mm-hmm,
and then they could get up and go.
mm-hmm.
And when you do that, you want to have the trash can closed. You wanna remove trash. You don't have to walk across the room to the trash can.
Okay.
Yeah, so remember your, barium enema bag's gonna be hanging on that IV pole, or that pump. So you're gonna take that off, lower it in the trash receptacle, like Miss Wallace was saying, so that should be right next to the table. You're also gonna have the clamp closed off, and, you wanna open up that clamp, because if the clamp is closed, the barium's not gonna come out. So you wanna open up that clamp, allow the barium to spill back into the bag, and then, deflate the balloon. Alright? Once I'm done with Miss Wallace, I'll get you guys, I'll go grab some of the equipment so you can see a little bit, in person how it appears.
So before we deflate the balloon, the barium goes back into the bag, correct?
Mm-hmm.
Okay.
Yeah, the last thing you wanna do is deflate the balloon, cause if you deflate the balloon while the barium's going back in the
We
bag,
could come.
the patient's already feeling like they gotta have a bowel movement, so they're probably just gonna push it out. And then you're just gonna have a big mess on your table, which might happen anyway. Sometimes it happens, especially with our older patients. So that's why I was saying that sometimes they have like these little inflatable donut rings that they'll blow up and put underneath the patient. It's like a little mini pool
Mhm.
underneath them. So that way, if they do have an accident, at least the intent is for everything to go in that little donut pool. So yes, the last thing is to deflate the balloon, and then you'll let the patient know that you're gonna remove the tip, and that they can get up and go to the bathroom. Sometimes we also massage the patient's stomach, cause we'll kinda keep checking in fluoro to see how much contrast is remaining in the colon. So sometimes if we massage the stomach, that kinda helps to push some of it out. You can also get an idea of how much is left, because the same amount that went in from the bag should be basically the same amount that comes out. So if you used a full bag and only half of it came out, you know that there's still a bunch in there. And sometimes you may not be able to get everything out, but we wanna try to get as much as we can out. So once we remove the tip, we'll have the patient go to the bathroom, and then once they come back, we'll take our KUB post-evac film.
About how long does it take for it to come out when you still have the tip in?
For the contrast to come back out, It depends on your patient, but usually like at least 5 to 10 minutes. Yeah.
So-
Because it's not gonna, even though it may take a little bit longer, you're trying to go quick, cause your patient's gonna be complaining. They're, you know, so you don't wanna take too long, like, so that's what I'm saying, even if there might be some left, like sometimes you just kinda get vibes off a patient, and if, you know, you feel like your patient's gonna walk up out of there, you need to hurry up. Yeah.
So with the posts, when they come back, is the KUB standing up or back?
For the BE, you could have the patient supine, the one that we typically do standing up is for the IVP.
Okay.
So you'll have them come back and lay on the table, do your last KUB. And then even once that's done, you still need to send that to the radiologist and communicate to the radiologist, hey, we've got that post-evac, did you get it? Is it okay for the patient to be discharged?
Okay.
If you have a patient that's non-ambulatory, you would do the same process, except they're not gonna get up and go to the bathroom, cause they can't. So usually we just try to get everything out, we massage their stomach, sometimes we'll kinda turn them a little bit to the left and the right, just to kinda help movement. And once we feel like we've gotten everything we can, cause you'll see the flow coming back through the tube. So once you start, you know, see it kinda slow down or just stop altogether, we'll just remove the tip and, deflate the balloon, remove the tip, and then we'll do our post-evac that way, if they can't physically get up and go to the bathroom.
Okay.
If you were to do a decubitus on the table, just to show you, as I said, typically you have the x-ray tube that's with the fluoro unit is not gonna be able to move out like this, but they sometimes will have another x-ray tube in the corner, that's just, there. So they would just bring that over. Miss Wallace, can you turn on your side for me? So they would have the patient turn on one side. And for this one, they're gonna have to use a holder because the receptor isn't gonna stay up by itself. So they can either do a holder, like that one over there. I've noticed some sites now have holders that will clamp onto the table and can hold the receptor. So you might have that, or you can just do it the good old fashioned way, put the receptor right behind the patient, put some sandbags behind it to hold it, or tape it in place. You wanna make sure that if you are, if you're doing the cross table in this manner with the patient on the table, you wanna make sure you're using a grid, right? Because the wall bucky has the grid built in, but this one, this grid is not here, so we wanna make sure we put that grid on before we make the exposure. My sandbags.
There's one right
Oh, I
there.
see them. So, I've got the mid part of the receptor should be in alignment with the iliac crest, I'm gonna come down a little bit. And then you wanna make sure that you're aligning the x-ray tube to the patient. So you still wanna go midline, to the mid-sagittal plane. And then what marker should I put here?
Left,
So I can put my left, and then what position is this?
right, left.
Right lateral decubitus. Alright, so it's my right lateral decubitus, I'll put my left marker here. Make my exposure, tell the patient to hold their breath, and then have them turn the other way, which I'm not gonna make West Wallace do. But I would have them lay on their left side to do the left lateral decubitus, because remember, you gotta do both. But if you were gonna leave the patient on the table, this is more so how it would look. Which sometimes they do, because as I told you, the patient's gonna be complaining. So as opposed to putting the patient like back on their stretcher and then bringing them over here, sometimes it is a little convenient just to do it this way. So any questions with the VE? Alright, almost done. So I'm just gonna show you the positions for the urinary exams we talked about. Ms. Wallace, you can lay back on your back for me. So 2 of them I'm not gonna do because the obliques, well actually the IVP, we've already gone over these positions. So the IVP, you just need your regular AP. And then the obliques, because why are we doing obliques with the IVP?
To see
The ureter, one side of the ureter and one side of the, opposite side of the kidney.
Right, so depending on what oblique you're gonna do, it's gonna highlight one ureter. And remember, we talked about in lecture that it's gonna change the positioning of the kidneys. Normally, when the patient's AP, your kidneys are not in a true AP, they're more so oblique. So when you do the oblique of the abdomen with the patient, it's gonna put one kidney parallel to the receptor and the other one perpendicular. So that's why we're gonna do both. Now what I am gonna show you for the IVP, it's not written on there, but I'll just add it in. As a part of the AP, not only are we doing just full KUB centered at the iliac crest, we're also gonna do one a little higher. Remember the first initial shot, after we push that first syringe in contrast, is gonna be high up because we wanna get the kidneys included and we turn our receptor crosswise, okay? So you should already have your receptor in the Bucky tray positioned this way, and more so positioned in alignment with the patient's body habitus and where you want to be. So quick rule of thumb with this one. So in line up here, you want to put the bottom, if the bottom of the receptor is where the patient's iliac crest is, you're good. Okay? So I'm going to bring the patient down a little bit. I'm coming to the angel. Alright, so Ms. Wallace, iliac crest is about here, so it's in alignment with the bottom of my receptor.
Okay.
Alright, I'm already lined there, so that's good. So the only thing I need to do now is come to my mid-sagittal plane, right there, and then I could collimate in some. So that's where you want to be. Now you're going to come and push your first syringe of contrast material. Because once you push that first syringe, you want to have all of this lined up because it's already going to start showing in the kidneys. Remember we talked about that blushing phase. So you want to make sure you capture that. So you push that one syringe, and it's probably going to take you maybe about 2 minutes, 2 to 3 minutes to do, because that contrast material is pretty thick. It's, although it appears clear, it's not like the consistency of water. It's got some substance to it. So when you're pushing it, you're going to have resistance. So it's going to take you about 2-3 minutes to push through. Once you push it through, you want to give your patient taking a deep breath in, let it out. The diaphragm goes up, hold your breath, and then you do your exposure. So that'll be your first film. Then you're going to come back and push that second syringe, because remember they're typically going to get that 2 syringes, especially if it's an adult. Once you do your second film, you're going to take another image of the kidney. We just refer to it as like the kidney shot. You take another image like this with the receptor crosswise, and then after that, you're going to turn the receptor portrait and do a full KUB. So by that time, you should be at your 5-minute mark. Remember, for your IVP or IVU, it's a 5, 10, and 15-minute film you're doing. So this will be your first full KUB, which you will document as your 5-minute. We're going to go to the iliac crest. Make sure we open back up our collimation for a full KUB, because we want to see what's going on with those kidneys and see ureters starting to fill and bladder. So you do your 5 minute like this, your 10 minute, and your 15 minute. Sometimes they will ask for obliques, so that's why we talked about that and what you're seeing. So it'll just be the same obliques that I started with, with the BE. With this one, once the radiologist has all the overheads that you did, so it should be about 4 or 5 films. Before you do your post-void, remember you're gonna check with the radiologist to make sure they don't need anything else before you have that patient go to the bathroom. Alright? So if you have a walkie-talkie, go get up and go to the bathroom. If you don't have a walkie-talkie, you might need to give them a bedpan or urinal to go to the bathroom. If you have a patient that comes with a catheter, they typically will clamp the Foley urinary catheter, clamp it closed. So you would just open it up so the bladder could be emptied into the bag. And then you're gonna come back and take your full KUB post-void film. Make sure you annotate it on there as a post-void. Typically, when they come back, if they're a walkie-talkie, we like to do these upright because it could show certain pathologies to the radiologist. So if they're a walkie-talkie, have them come up against the wall, Bucky, and do it upright. All right, questions? All right, for cysto, you're just only focusing in on the bladder region, okay? Because a cystogram is for the bladder. So we're gonna come way down. Angel, does it say to go in alignment with the ASIS or below? For your central ray for the cystogram.
Yeah, it just
It
says
doesn't say?
axial. It says AP axial.
Well, the central ray should still be the same, so let's just use what it's saying. So it says centered, 2 inches superior to the pubic symphysis of the sagittal plane. Okay.
That's the same, just
Oh,
not
here.
angle.
So this is the AP. Like AP axial, right? So I got an AP.
That's, yeah, we were like looking for it.
Well, they're all still 2 inches superior to the pubic symphysis, so, alright.
2 inches inferior?
Superior
Superior.
to the pubic symphysis.
Okay.
Alright, I'll leave it there. So I'm aligned here. So where I am is about 2 inches above the pubic symphysis, so I'm just gonna go up a little bit. Wallace, point to your ASIS so we can just have a reference. So it looks like it's about half an inch below the ASIS. You could bring in your collimation quite a bit because you're only really concerned about the bladder.
Okay.
And they will look for reflux, like we talked about in the ureters, but you'll still be able to see that here because the bladder's not huge. So this will be your AP. Outside of the AP, we'll do obliques as well. So we would just oblique the patient in the LPO and RPO. So you guys already know about the obliques.
Mhm.
One thing you want to keep in mind that I didn't mention earlier is when you're doing the obliques with the BE as opposed to the IVP or IVU, the BE, you're going to have the patient 45 degrees, but the IVU, IVP is a little less. I think it's like 20 to 30 degrees you're going to oblique them. It's not a full 45. So we will do our AP centered over the bladder, and then we'll do our obliques. Now, when you do your obliques, Ms. Wallace, turn towards your left a little bit. You can use your ASIS as a reference.
Turn towards me.
You can use your ASIS as a reference. Okay. And you can, this is your ASIS, right? So So I'm on her ASIS, and you could go 2 inches medial to that landmark. So I came in 2 inches medial. So my finger is on her ASIS, and I'm going in 2 inches medial to that. And that will be your centering point for your obliques. And then you'll just do the same thing when you've got the patient the opposite direction. So we always do an AP, obliques. I know your textbook says axial there. I don't think that's something they commonly do. Usually it's just the AP and obliques, and sometimes they don't even do the obliques because they see everything what they need to do on the AP. With the cystogram,
Wait, you said oblique are how much?
20 to 30.
well, I didn't say
This is-
specifically for the cystogram, but for the BE, it's 45. For the IVP, it's less. It should be about 20 to 30. What is it saying for the cysto?
10, 15.
Okay, so it's even shallower.
No, that's the axial.
This says patient should
45
be
to
semi-supine, 45 to
60.
60 degrees oblique
Okay.
for posterior lateral bladder.
In the junction.
Okay, so it's a lot steeper.
Mm-hmm.
Okay. And then just to go check and see what it says for the IVUs. That one I think is like around 30.
Yes.
Okay. So for the cystogram, you're gonna oblique more, so I would just have the patient roll more towards their side. And that would be your steeper oblique. So
And
then
that-
that's gonna change my central ray, cause now her ASIS is more internal, so I need to make sure I adjust my positioning, or where I'm centering.
So 2 inches.
Mm-hmm.
medial.
And that's the IBU?
This is the cystogram, cystography. Cystography, they typically don't do a post void. Do you guys see that written there? A post void for the cysto?
I just see RPO, ALPO, optional lateral, AP, posterior oblique. I don't,
Yeah, AP erect post void IVU.
Yeah, I think I wrote this in the wrong spot. So I'm just gonna write the post void up here.
Right.
different.
Correct. Right in my spot.
Yeah, cause once they have those images done with the cysto, they pretty much just, remove the catheter that was placed in the patient and discharge the patient. Miss Wallace, I'm gonna take this one. And the cystogram is typically done, usually they have like a dedicated room, as I was telling you guys in the OR surgery, that they do these procedures in for, the cystograms. So you won't probably really see it in the department.
If the patient doesn't have a catheter, they're still gonna wanna go to the bathroom afterwards, aren't they?
Yes, so once you're done with the exam, you can let the patient, go to the bathroom, before they leave. For all of these exams, you wanna make sure you're instructing the patient to drink plenty of water, so they're not
Yeah,
constipated with the
okay.
barium enema, and to help
Mhm.
flush that contrast material out from the urinary studies. I felt like I showed you a lot, maybe I'll hold off on the femur, or do you guys want me to go through the femur?
I feel like it was a lot.
Okay.
Yeah.
Alright, so we'll do the femur, when you guys come back from your break, and we'll just tie that in, we'll do the femur, hip, and pelvis. But I don't wanna delay you guys in clinic, so if you see femurs, you can go ahead and comp since we lectured on it,
okay.
yeah. Have you guys been seeing that, femurs?
I've
I
seen
saw
a couple,
one.
yeah, I've seen like a couple.
Okay.
The frog hip.
Mhm,
and
okay.
We
Not
actually
us,
had
we
to
do the, frog and, yeah, with the kids, for
Okay,
the pelvis area.
I've done it with elderly patients.
Mhm.
And we did have one where we had to do like 2 because his
Mhm.
femur was so long.
yeah, you're simply gonna have to do 2 on all adults. The only time you can probably get away with doing 1, is on pediatrics. Yeah.
Talking about with the, Which one,
for the femur, because it's so long.
okay.
Yeah, we're always gonna have to do
Both.
superior and, distal and proximal, I think is how it's referred to.
I had
But
to
yeah.
do, I had to do one of those.
I think we actually have to do
He
three.
was like, did you do it? I was like, I don't, yes, no, maybe, I don't know. He's like, I'll show you. So we like did it together, like, okay.
Yeah, so now if you see them, like, go ahead and feel free to comp on them. Alright, thank you, Ms. Wallace. Let me see if I can get that contrast up so you guys can see what it looks like. I'm gonna turn on the light. You guys have any questions?